Hi everyone, I hope you all are well. Today in this video, I am going to try and answer a question that do you really need to know about occlusion? And whenever I am trying to learn anything, I ask myself, why should I bother learning that thing? Because time is very precious, resources are very precious. We want to spend our time and resources into learning things which is going to impact us most. As you all know that I teach occlusion and full mouth reconstruction, so this is a very dear topic to me. So let me ask you a question: that have you had a situation where you have removed all amalgam which has been worn down, and you've done nice composite restoration, really nice cusp anatomy and everything, and when you ask patient to close their mouth, the occlusion is very, very high, which means the patient's only contacting on the restoration. And then you start removing the restoration, and then what happens is you come up with a shape which is exactly the same shape it was when patient had an amalgam restoration, which is quite dished out like a cavity. Have you had a situation where you have prepared a second molar and for a crown preparation or indirect restoration, and you know that you have reduced enough, you reduced 1.5 millimeter or 2 millimeter, whatever the specification of the onlay is or a crown is, and when the final crown comes, the crown is way too high, and when you start drilling the crown to adjust the occlusion, so much so that you perforate the crown, or the crown becomes really thin in the occlusal area. Or have you treated a patient who repeatedly breaks the restoration? So you treat one tooth and then patient breaks the other tooth, then another tooth and another tooth. If you have any of these scenarios, then you need to learn about occlusion, because the question number one, where you see patient with amalgam, most likely what has happened is because the amalgam has worn down, there is a supra eruption of the tooth on opposite to that tooth, and you need to have a communication or explanation or discussion with patient before you carry out that restoration, that what you are going to do with opposing tooth. Are you going to do orthodontic treatment to remove that tooth into its position, or are you going to do enameloplasty? How are you going to deal with this problem so that patient don't end up with dished up restoration? The second question was about the second molar. Now this is many times happens when the second molar is first point of contact, which is the patient's CO, centric occlusion, is onto that tooth which you are going to prepare. By preparing that tooth, what you are doing is you're going to reduce the slide which patient has from CO to ICP. And don't worry about these terminologies. I will be going through these terminologies in future videos. But today you just need to understand that patient, when they close in one arch, most of the time they close on one tooth first, and then the jaw slides into maximum intercuspation. And if you're preparing that tooth which is in the first point of contact, what you're doing is you're reducing the vertical dimension. So without changing occlusion, you are changing occlusion of the whole mouth and reducing this vertical space. And that's why, although you have reduced 2 millimeter, the space becomes 1 millimeter. If you reduce 1 millimeter, space becomes 0.5 or 0.4 millimeter. So one of the way to overcome this is that make sure that once you reduced, first of all, you have checked that patient's first point of contact is not on that tooth. Articulate models using semi-adjustable articulator, and make sure that once you've done any preparation, you relax patient's jaw and check in patient's relaxed position what is the reduction of your preparation, and try it out in provisional. If the provisional keeps fracturing or patients keep breaking that provisional, make sure that you address that issue first before taking final impression. And the third question, when patient keeps repeatedly breaking things, then you need to look at some of the warning signs when patient comes and see you. What are those warning signs for very difficult patient or difficult mouth to treat? One of the warning signs is when you ask patient to close their mouth, when they are relaxed and they cannot locate their jaw. Now, yes, most of the time when you ask patient to bite their teeth together, and patient tends to bite in weird position, and we are all aware of that. And I'm not talking about that kind of scenario. I'm talking about when patients are relaxed and you know that they can close their teeth properly, but they just cannot locate their teeth. And that could be because patient's muscles needs deprogramming and they are very active and very tired from bruxism. That could be one of the reasons why patient cannot locate their bite properly. The other case is when patient has multiple broken teeth. Now, yes, you can say that those teeth were heavily restored and that's why patients breaking those teeth. However, we have all seen heavily restored teeth in someone's mouth which has lasted for years and years and years. So occlusion has some part to play on this. Having said that, obviously if tooth is heavily restored, especially with amalgam, it is highly likely that amalgam is also one of the cause of cracks and breakage of the teeth. And the third is when patient complains of pain near their jaw. So if patient comes to see you and they're saying that when they open and close, they're feeling that pain around the jaw, or if you ask patient to bite together and clench really hard, and they're feeling pain around the muscles, then you need to make sure that you assess that patient thoroughly about the occlusal. You can do proper occlusal assessment before treating this patient for any comprehensive treatment. So this is some of the questions which I'm trying to answer, because when someone asks me whether I really need to know about occlusion, I personally feel yes, you need to know about occlusion, although it may not be that helpful in day-to-day practice, because in day-to-day practice we are discussing about static and dynamic occlusion, where patient closes their mouth, tap tap tap, you check the occlusion, and you ask patient to do some excursive movement and you check occlusion. If that's fine, most of the time you will get away with it. However, you will get caught up with patients who are showing those warning signs, and you need to be aware of that. Occlusion usually matters when patient's parafunctionist. If patient's not parafunctionist, whatever you do will work most of the time, not all the time, but most of the time. And that's why many of our colleagues, even if they do not have complete understanding of occlusion, they can still practice really good dentistry, because most of the time when patient's not parafunctionist, it works okay. Also, it works fine if you're doing single tooth dentistry. When you start doing multiple restorations, you really need to know a thing or two about occlusion. So let's look at the 3 tips you need to know about this video. The first is, make sure you check about the warning signs. So when patient comes in, actively check about those warning signs before you're doing any comprehensive treatment. Check occlusion before any restoration. So make sure you check patient's occlusion, check bite, check contact points before you start restoring any teeth. Check the dynamic occlusion as well. Again, when you're preparing the tooth, you need to have this excursive movements to make sure your reduction is enough when patients going left and right, because most of the time we are good at checking static relationships. So we will ask patient to close their mouth and see if we've reduced enough tooth, but we forget to check in excursive movement. So make sure you check patient's excursive movement. I would ask patient to go on right and left, and just make sure visually that I can see that I have enough space. You could put a wax sheet, maybe of whatever diameter you want the reduction, between the teeth and the prep, and ask patient to do excursive movement, and you will be able to see any marks where you think that the reduction is less. So make sure you check occlusion before you start any treatment. And if patient has a supra erupted teeth, then please advise patient before you start treatment, because it will be too late after you've done the restoration, and then you will tell patient that, you know what, the upper tooth has supra erupted, and that's why I have to keep grinding your lower restoration. And patients now not happy because they were expecting nicer tooth-like restoration, and now they got some sort of dished out composite restoration. So make sure you do these checks and I will see you in the next video where we will discuss about why occlusion is so confusing.